All right, everyone. Welcome to another session of Unpacking Bedside Bioethics. This is our introductory bioethics education series hosted by the Center for Bioethics at the University of Minnesota. Today's session is all about informed consent, and we have some great speakers. I'm very excited for this session. But before we start, we have a couple of notes that I want to make. First, if you are part of the mHealth Fairview system, the Center for Bioethics provides ethics consultation for the system. So if you have questions and ethical dilemmas you want to discuss, we're available to discuss those. You can reach us through the pager. We're also, our contact information is available on the intranet, and that service is 24/7. I am excited to introduce our two fantastic speakers today. We have Dr. Thad Pope, who is Professor of Law at Mitchell-Hamlin School of Law, and Dr. Miriam Shapiro, who is the Assistant Professor of Pediatrics at the University of Minnesota. Both of these speakers are part of the University of Minnesota Medical Center Ethics Committee, and both are part of our affiliate faculty program at the Center for Bioethics. We're so excited that they're sharing their expertise with us today. This is going to be a great session. So neither presenter has financial relationships to disclose, and neither will discuss off-label use. If you have questions during this session today, please use the Q&A feature to ask any questions for our speakers. You can also use the Q&A feature to let our center staff know if you're having any technical difficulties, and we'll do our best to work those out so that you can get access to the presentation. This session is being recorded. A recorded full-length recording will be available at the Center for Bioethics website. And we really appreciate if you can take the time to do an evaluation for this session. We take those evaluations really seriously and use your feedback to create future sessions for this series. So thank you so much if you've attended and filled out an evaluation, and we look forward to your feedback. All right, if you're seeking credit, we have two opportunities for credit for this session. First, we can offer a certificate of attendance. So there is a form in the chat called presentation details, and information about requesting a certificate of attendance will be in that form. You must attend at minimum 75% of this talk to receive that certificate. If you are a University of Minnesota student and you're looking for IPE credit, we have an opportunity for you to do so. Please go to that presentation details document. We'll have a 15-minute discussion after this session, and then you'll be asked to independently complete a reflection form. And that is just for University of Minnesota students with active status in health professions program. So if you're looking for that, also check out the presentations details document. All right, so now I'm going to hand it over to our two presenters who are presenting on informed consent beyond consenting the patient. Take it away, Dr. Pope. Looking forward to it.
All right, thank you. I'm going to share. Okay, so I am Thaddeus Pope, and I'm going to start, and I'm going to hand it over to Dr. Shapiro. So consent matters. It matters for three big reasons. It respects patient autonomy and self-determination. It assures value, congruent care, helping assure that the patient gets the treatment that she wants and doesn't get the treatment that she doesn't want. And it also satisfies legal requirements. So we're going to start with a baseline poll. I'll read this. A 55-year-old man arrives for a planned outpatient surgical procedure. The anesthesia team plans to start a nerve block in the pre-op area, but because of the patient's anxiety about the nerve block, he's given midazolam. And to mitigate pain associated with the needle stick, he's given fentanyl. So he relaxes enough for the nerve block procedure to be completed. Now the surgeon then arrives to obtain consent for the surgery, has a discussion with the patient, and the patient signs the consent form. So the question for the poll is, were the requirements of informed consent met? Yes, no, or I'm not sure.
We have some feedback already coming in. Those of you who are live should be able to see the feedback, but for recording purposes, I don't think it'll show up. But we have about 75% saying no, 20% saying I'm not sure, and about 6% saying yes. That's holding pretty steady. All right, I'm going to end the poll. And these are results. 75% no, 20% I'm not sure, and 7% yes.
Okay. That may be higher of a no response than we expected, but we'll come back. Okay, that was just to get a sort of a baseline position from everybody. Okay, so a couple points about the scope of what we're going to talk about today. There's sort of three limits. Limit one is, obviously this is just a lunchtime 1 hour webinar, so we're only going to scratch the surface of all the stuff around informed consent. Second, we're going to assume that the decision maker has decision-making capacity. Typically, that's going to be the patient, but Dr. Shapiro is going to talk about the pediatric context in which the decision maker is the parent. And we're also going to assume that the decision maker is not under coercion or duress. In other words, they're making a voluntary decision. And then third, we are going to focus on clinical informed consent. So consent for diagnosis or treatment. There are different special rules that govern consent in the context of human subjects research. All right, so let's start with some history. And we're going to go all the way back to 1847, right? James Polk is the president. Thomas Alva Edison has just been born. Alexander Graham Bell has just been born. And the American Medical Association has just published the very first edition of its Code of Medical Ethics. And in that book, they advise physicians, do not consider the patient's own crude opinions, right? This is an era of hard paternalism, right? You're the physician, you're educated, you know what needs to be done. You don't need to check in with the patient about what they think or what they want. You know best. Fast forward from 1847 up to 1905. Now, Teddy Roosevelt is the president. Impressionism is all the rage. People are starting to drive cars. And we recognize the concept of medical battery, right? The idea that you really don't touch the patient without consent. You don't do things to the patient without consent. The idea here is there's a mismatch between what you did and what you got consent for, right? So the idea is for the very thing that you didn't have consent. And this can come in four forms. One is you didn't have any consent at all. So there's a growing number of cases across the country where the patient has a pulse, a DNR order, an advance directive saying, I don't want to be resuscitated. But they are resuscitated, they are intubated, they are given CPR, and those patients are getting verdicts and settlements because that's a medical battery. Another form of battery is where what the patient consented to something, but it's a different procedure than the one that you did. And we also see this year, 2023, a lot of legislation and a lot of court cases involving pelvic exams. So the situation is a female patient has come in for some kind of procedure. She's sedated. And then the clinicians take that opportunity to educate the trainees on how to do a pelvic exam. The problem is that's not what the patient consented to. She consented to something else. And now the thing that you're doing is different than the thing that she consented to. Another form is maybe what you're doing is the same procedure that the patient consented to, the very same procedure, but she consented to doing it on a different part of the body than the one you did. And the classic case from the Minnesota Supreme Court is where the patient consented to a procedure on her right ear, but the physician ended up doing that procedure on the patient's left ear. And that was a medical battery. And then finally, maybe you did the very same procedure that the patient consented to on the very part of the body that she consented to, but a different doctor did it than the one the patient consented to have doing the procedure. And so you again, this is a big issue around the country where the patient thought that the board certified attending surgeon was going to do the procedure, but in fact, they were doing maybe two other surgeries at the same exact time, in which case your surgery was primarily done by fellows or other trainees. Okay, so that's battery. Fast forward now from 1905 up to 1972. Right now, Nixon is president, The Godfather is the film of the year, and ABBA has just been formed. And we recognize the doctrine of informed consent. Now here, there's no mismatch. What the patient consents to is the very same treatment that she gets. And the classic case, or the most seminal case on informed consent, is the case of Jerry Canterbury. He was suffering really, really bad intractable back pain. And ultimately, his physician recommends a laminectomy, a type of back surgery. The thing about laminectomies is they entail an inherent 1% risk of paralysis. Well, Jerry Canterbury's physician didn't tell him about that 1% risk of paralysis. And in fact, Jerry postoperatively was paralyzed. So Jerry admits, yes, I did consent to the laminectomy. I did consent to it. So there's no battery issue here. He got the same thing that he consented to. But what Jerry says is, I wouldn't have consented if the doctor's disclosure had been appropriate. I wouldn't have consented if I knew that risk of paralysis. So this is a completely new theory in 1972, that doctors actually have a duty to disclose not just the procedure that they're doing, but the risks, benefits, and alternatives to that proposed treatment. And that was recognized most famously in this Canterbury case, which said that physicians must obtain not just the patient's mere consent, but also the patient's informed consent. You have to tell the patient the risks, benefits, and alternatives to the proposed treatment. But which ones, right? Which risks and benefits, right? Because there's a lot of risks especially from surgical interventions, and clinicians can't go over all the risks. So how do we measure which of all the information we could disclose, which information must we actually discuss with the patient? In other words, how informed does the patient need to be? Well, there's two main measures that we have, or two main tests. The majority rule in both law and in bioethics, and the rule that we follow in Minnesota, as recognized by this 1977 case, is that the physician must disclose all the risks that a reasonable patient would find important. And just to apply that to the Canterbury case, right, you must disclose what a 19-year-old patient considering a laminectomy would deem significant or important. What would they want to know about that procedure? So this is a very patient-focused standard. In contrast, just over the border in Wisconsin, it's a very different standard. It's very much less patient-centered. There, the duty is measured by professional custom. In other words, the physician in Wisconsin must disclose what a reasonable medical practitioner would have disclosed under the circumstances. In other words, disclose what a reasonable physician normally discloses. So this is a physician-focused standard. And as the Wisconsin Medical Society observed, it's not as broad as the Minnesota patient standard, and it lessens the burden on physicians. So it's sort of a lower standard. So let me just compare those two standards quickly. And I have these three columns. So Minnesota and Iowa both follow the patient-oriented standard, and Wisconsin follows the physician-focused standard. And take two issues that are kind of hot and being discussed a fair amount in the literature and in courts across the country. One is treatment costs, right? So should physicians disclose the costs of the treatment, right? Because we have a lot of issues of financial toxicity. And secondly, should physicians disclose their experience with the procedure that they're about to perform? So especially where the treatment costs are very, very high, so for example, with new cancer drugs, and where the clinician's experience is very, very limited, so this is the first time they're going to perform this heart surgery, is on you. In those situations, in Minnesota and Iowa, there's arguably a duty to disclose those things because a reasonable patient would think that's kind of important or significant to know those costs and to know the lack of the clinician's experience. But in Wisconsin, probably no duty to disclose those things because physicians don't customarily normally disclose them. And you only have a duty to disclose pursuant to the standard of care. Standard of care is not to disclose them, therefore there's no duty to disclose them. Okay, so let me just now quickly end up with two questions that came up before the webinar that people submitted. One was, are we moving toward a national standard of care? I just pointed out some variations between Minnesota and Wisconsin. And I think the answer is yes, but very slowly. And here's why. CMS, or Medicare, is the single biggest payer of healthcare in the United States. And for the last few years, they have been requiring patient decision aids as a condition of payment. In other words, if you don't use the decision aid, you don't get paid. Well, what are decision aids? These are evidence-based educational tools. It might be a video or an interactive app or just printed literature. Either way, what they do is they present the patient's options clearly and graphically. And there is robust evidence to show that these decision aids are super effective. We have more than 130 randomized controlled trials involving more than 30,000 patients with 50 different conditions. There have been meta-reviews, systematically reviewed by the Cochrane and by others. And what we see are 6 really big benefits: vastly improved knowledge of the patient, more accurate expectations from her healthcare, more value congruent choice, higher patient satisfaction, less decisional conflict, and less patient anxiety. So let me just give you a quick example of what Medicare has been doing. Back in 2018, they focused on implantable cardioverter defibrillators, right? Little ICDs shock the heart back into a normal rhythm. So this is covered. It's a Medicare benefit. They'll pay for it. But they say before implantation, the patient must be educated with a, quote, evidence-based decision tool. And so basically CMS is saying you got to use this decision aid. Well, that kind of assures a level of uniformity that everybody, no matter what state you're in, must use that decision aid, which provides certain benefits, risks, and alternatives to the ICD. And that kind of gets you to a national standard. And then one other question that that came in ahead that I think I wanted to answer was this, because it also gets to what's going on at the national level. So the question was about limited English proficiency. Right? Tens of millions of Americans have limited English proficiency, about 1 in 13 in the entire population. And it, of course, doesn't matter if the physician is discussing risk, benefits, and alternatives to proposed treatment. If the patient doesn't understand English, she doesn't understand what the physician is saying, right? Whatever the physician is saying is not going in. We also, real similar issue with hearing impaired patients. Right? Tens of millions of Americans have hearing impairment, and especially among a lot of older Americans, that hearing impairment becomes disabling. So the question that came in was, how should clinicians communicate with limited English proficiency patients, and how should they communicate with deaf patients? Well, on this one, this answer is actually relatively easy, because this is specifically addressed by Section 1557 of the Affordable Care Act, and by regulations that implement that act. And what they say is you have to use a qualified interpreter, both for the hearing impaired patients and for the limited English proficiency patients. You can't pass notes back and forth. You can't lip read. You can't rely upon a companion that accompanied the patient to the visit. You must use a qualified interpreter. So I'm going to stop here and turn it over to Dr. Shapiro.
Dr. Shapiro, you're on mute.
Thank you, Dr. Pope. Thank you, Dr. Connor-Rensis. So far we have talked about why we obtain informed consent. That informed consent entails describing a treatment option, its risks, benefits, and alternatives, and how we decide which information we should disclose. If we do all these steps, we have met a legal standard of informed consent. But this is not enough. In order to meet an ethical standard of informed consent, we must also elicit understanding from the patient or their surrogate. Which raises the question, how much understanding? This is a really complex issue and we can only scratch the surface here. But generally, we need to ensure that patients or their representatives understand what the treatment is, what will actually happen, and the implications of the treatment in the short and long term, which can be a challenge. We know that it is difficult to truly understand things that we have not experienced before, or that have the potential to change many aspects of our day-to-day lives. Can I truly understand what severe postoperative pain will be if I've never had a major surgery before? Possibly not, but this doesn't mean we are exempted from attempting to explain. There is a balance between providing too little information such that the patient is uninformed and too much information such that the patient is overwhelmed with details. And there's a need to identify what the right information is for this patient. So our task is to check, to ask the patient to explain back to us what they understand and to use that as a launching point for further discussion, to mitigate the effects of stress on decision-making as much as possible. And we know that much medical decision-making either induces stress or occurs during times of high stress. This may mean we seek to involve additional people who may help a patient understand, a family member or an advocate. And we should also use decision aids when available, as studies show improved understanding with the use of decision aids, as Dr. Pope described earlier. So then we get to the question of who should obtain consent. Which of these people should do that job? Could it be anyone? Ideally, this is the clinician who will be performing the intervention, though there are considerations for trainees or advanced practice practitioners who are trained in both the treatment or procedure that the consent is for and in the act of obtaining informed consent. What it should not be is the least trained team member who's sent into a room to get a signature on a piece of paper. This is to ensure that the person obtaining consent has adequate training and experience to provide the necessary information to the patient to make the consent process truly informed. And who can provide consent? Most ideally, a patient with capacity. And as we learned from Dr. Conner-Mancisi's talk on capacity, this is not an all or nothing state. So we should ensure that we are not working around a patient who with adequate supports would have the capacity to provide consent. If the patient does not have capacity, then a surrogate decision maker should provide consent. And we talked about this in our last session with Dr. Henriksen, who did a deep dive into surrogate decision making. In the case of pediatrics, most commonly a parent or guardian provides consent, or some people refer to it as permission, saying that consent really links to autonomy. And so this is a different situation. So what they're providing is actually permission, but I'll stick with consent for the most part. In pediatrics, though, we also try to obtain assent from the child when possible. So let's do another case. A 15-year-old girl is newly diagnosed with acute lymphoblastic leukemia, which has a 90% 5-year survival rate with treatment. The oncologist discusses the diagnosis, recommends starting chemotherapy immediately, and explains the side effects of treatment. The patient would like to wait 2 months before starting treatment because of important school activities, including final exams and a school dance. Scared about the diagnosis and wanting to respect their child, the parents do not give permission to proceed with the treatment. Do you? Go along with the family plan to delay treatment in order to build trust and rapport? Attempt to persuade the parents to consent through further discussions about the gravity of the diagnosis and consequences of delay? Contact risk management or ethics if you have those services available in your hospital, or report the family to child protection.
We've got some good results coming in. We'll wait till we get about 75%. And we might end the poll in about 30 seconds. All right, get your final answers in. I'm going to be ending the poll. All right, it looks like about 19% of respondents said they'd go along with the family plan to build trust and rapport. About 53% would attempt to persuade the parents to consent. 27% would contact risk management or ethics, and 1% would report the family to CPS.
All right, thanks for that. I think, it seems like the majority of you would the first thing you would do is attempt to persuade the parents to consent through further discussions. And that really highlights the importance of education and making an educated decision, and your fear as a clinician that the reason that this family is declining to go ahead with this treatment that you believe to be life-saving and critically important is because they don't understand the seriousness of that. So it's always a good first step. Go on and talk a little bit now about assent in pediatrics. So minors usually cannot provide legal consent. There are a few exceptions to this, but for now we will focus on the majority of cases in which minors are not deemed to have capacity. However, they are moral beings with dignity and rights, and seeking their assent signals respect and recognition of this fact, while also recognizing the limitations of children and adolescents as independent decision makers because of their range of cognitive abilities and maturity of judgment across their developmental stages. Ideally, seeking assent helps children become more involved in their medical care, fosters moral growth, fosters the development of autonomy, and improves self-management of a child's medical condition over time. The key elements to assent, as laid out by the American Academy of Pediatrics section on bioethics, are to help the patient achieve a developmentally appropriate awareness of the nature of their condition, tell the patient what they can expect with tests and treatments, make a clinical assessment of the patient's understanding of the situation and the factors influencing how they're responding, including whether there is an inappropriate pressure to accept testing or therapy, and finally, to solicit an expression of the patient's willingness to accept the proposed care. But I caution that we should not seek assent if the treatment or intervention is required and the child does not have a choice. Because asking, hearing no, and then doing something anyway would violate the moral standing that we're trying to respect through seeking assent in the first place. We should still go through the first 3 steps, though, of ensuring the child knows what to expect from their medical treatment and why. When possible, it's important to allow children and adolescents as much of a voice as is reasonable in their medical care. So the child may not have a choice about having an IV placed and receiving medicine, but maybe they could have a choice about which arm the IV goes into. And so finding those ways that you can involve the child and get their permission for the parts that they can control remains important. Let's move on to talk about some exceptions to informed consent. Though there are others, here we will focus on the main ones. The first is emergency treatment, where there is a presumption of consent in the absence of something like a POLST, so existing outpatient orders that say that you aren't to be resuscitated in the case of an emergency or something like that, or a known DNR. There is a presumption of consent for life-saving therapy. However, there is still an obligation to seek consent from either a patient or their appropriate representative as soon as the situation allows. A second exception is court-ordered treatment, because here there isn't a choice to be made, it's court-ordered, so refusal would not be accepted. So it's similar in this way to the case of obligatory therapy for a child. If you can't say no, you shouldn't ask. And then finally, patients or surrogates can waive the right to provide informed consent. So let's jump into another case. A pediatric patient who has been in the ICU for 5 days needs a central venous line, or the treatment team would like to place a central venous line to aid in therapy. You start to obtain consent from the parent for the procedure, and they stop you as you start to talk about the risks of the procedure, saying, "I trust you. If you think this is the right thing to do, just do it." What do? Do you force the parent to listen to the risks and benefits prior to letting them sign the consent form, accept their signature with no further action, or accept their signature and document their waiver?
Lots of answers pouring in. We'll probably have about 30 more seconds for you all to make your quick decisions. All right, I'm going to end the poll, so get your responses in. All right, it looks like about 71% of you answered. 42% would force the parent to listen to the risks and benefits prior to letting them sign the consent form. 2% would just accept their signature with no further action, and 56% would accept their signature and document their waiver.
Thank you, guys. I think that I like this breakdown because I think it acknowledges that documenting waiver is important, and that there are circumstances where waiving the opportunity to listen to risks and benefits doesn't feel quite appropriate. I will also just put on the table, as a busy clinician, I certainly have accepted a signature with no further action and moved along. So not the ethical choice, though. I think as your answers showed, it's in this case, it's probably okay to waive consent. It's not a terribly preference sensitive decision, but there are situations where the outcome, whether you do something or you don't do something, is highly preference sensitive, and waiving informed consent would potentially be inappropriate. The other thing to consider is if it's a surrogate who's waiving consent. The surrogate's job is to be available and willing to weigh risks and benefits on behalf of a patient. And so if they are giving up that responsibility or failing to fulfill that responsibility, perhaps you should seek another surrogate. So when exceptions apply, whatever they are, emergency, court-ordered, waiver, something else, we should document them in the record. In addition to exceptions, there are also limitations to informed consent. If we are seeking informed consent, then we must also accept informed refusal. So like the situation of the required pediatric therapy and assent, we shouldn't ask the question if no will not be accepted as an answer. But there are differences in how informed refusal is treated in adult and pediatric medicine. Adults with capacity are allowed, out of respect for their autonomy, to make quote unquote bad decisions that the clinical team does not agree with. This is less often the case in pediatrics. And similarly, there are limitations to surrogate decision-making. In thinking about parental refusal of recommended treatment, let's think about the framing of parental decision-making first. When making decisions about medical care for their child, a parent's task is less about their rights than about their responsibilities. So parents have a duty to protect and promote the well-being of their children, but this applies both in health and non-health related spheres. And we recognize that this doesn't always mean acting in the absolute health-related best interests of a child, because there may be a competing child or family interest that must be balanced. The ethicist Lynn Gillum introduced the idea of the zone of parental discretion as an ethical deliberation tool to use when parents disagree with the treatment recommendations of a medical team, or in our discussion, when they provide informed refusal. Decisions that fall within this zone range from those that are absolutely optimal for a child's interest to those which don't fully meet some or all of a child's interests, but are not so bad as to cause harm to the child. So in refusal of a recommended treatment, the question then becomes about a threshold of harm. Parental authority can be challenged if the parent is making medical decisions that place a child in serious and imminent harm, such as refusing a potentially life-saving therapy. This is because the state also has an interest in protecting children from harm. But despite this interest, refusing to accept parental decisions isn't something we should do often or undertake lightly. And an ethical process should be utilized to ensure that this is the most acceptable approach. There are several examples in which the legal system has overridden parental refusals of therapy, but interestingly, there are also ones in which it has affirmed a parent's right to choose to forego life-saving therapy with assent from a mature teen that this is consistent with their wishes as well. Sorry. Just as parents can be prevented from making harmful decisions for their children, surrogate decision makers also don't have unlimited authority. They should be making decisions for a patient based on the prior expressed wishes of the patient, substituted judgment, or consideration of the patient's best interests. And if you find yourself in a situation where you're questioning the decisions that a surrogate decision maker is making, that might be an opportunity to consult your ethics team to help you distinguish between values-based best interests or medical-based best interests. And we'll be talking more about the standards for surrogate decision-making in our next session, so stay tuned for that. I do want to make a quick mention of CPR because it's a unique instance of consent. The only intervention we need consent not to do rather than to do. Decisions against CPR to not do CPR can be made without the consent of a patient or surrogate in certain circumstances, though this tends to be institution specific and should only occur through an established process. We have time for one more case. We will end with this one. An 82-year-old woman with advanced dementia is hospitalized following a stroke. Unfortunately, she doesn't have anyone who can serve as a surrogate decision maker for her. Her clinical team believes that the most appropriate medical option is that she should be transitioned to hospice and consults ethics given the lack of a surrogate. Supported by hospital policy, the clinical and ethics teams have agreed that in the absence of an appropriate surrogate decision maker, they will proceed with the medical best decision for this hospice eligible non-decisional patient and refer her. The hospice agency representative arrives to enroll the patient and has the non-decisional patient sign the hospice consent documents. A member of the clinical team is very concerned about this and wants to stop the transition to hospice, fearing that asking the patient to sign the documents has made the entire plan unethical. How should the clinical team proceed? Sorry, there we go. How should the clinical team proceed? Should they continue with the existing medical plan rather than plan to transition to hospice because of the inappropriate signing of the hospice consent form? Should they continue with the plan to enroll the patient in hospice, but have a hospital representative who was involved in the decision sign the consent form as a surrogate decision maker? Should they notify state licensing authorities about the inappropriate consent procedures of the hospice agency? A and C, B and C?
There are lots of options in this one, so make sure to read through all the options. Really good responses so far, good response rate. I'll end the poll in just a few seconds, so make sure to get in your final thoughts. All right.
Great. Go ahead.
So it looks like about 6% would just continue with the plan, continue the existing plan and not transition to hospice because the process of signing consent was inappropriate. 30% would do B, continue to enroll hospice, but change the sort of consent process. And then 2% would notify state authorities. 18% would do both A, continue the medical plan and notify the authorities, and 44% would do B, continue with the hospice care and notify authorities.
Thank you all for participating so actively in our polls. It's really nice to get to get your thinking and see how you're thinking about this. I will say this was a tricky one. As Dr. Pope and I were preparing this talk together, we really wrestled with this case and the many dimensions of it. And so I want to acknowledge that it's complicated and not entirely clear. So thank you. So I hope that through this conversation, we have managed to convince you that consent is not just a signature on a piece of paper, but it's actually a process that we need to go through and that isn't complete if all we have is a signature on a piece of paper. So to summarize, informed consent allows patients to exercise their autonomy and receive medical care consistent with their goals. It requires the patient or surrogate to have capacity to provide consent voluntarily. It includes disclosure of medical treatment risks, benefits, and alternatives, and requires that the patient or surrogate understand those things. It can be skipped in emergency cases and can be waived. Pediatric patients should be allowed the opportunity for assent where appropriate. And as an idea, informed consent is continuing to evolve to include aspects of care that haven't traditionally been included, like cost. And with that, we'll move on to our Q&A.
Great. Thank you so much, Dr. Shapiro and Dr. Pope. This has been a really fascinating presentation. I'm really looking forward to discussion. We've got some great questions in the chat. Dr. Pope, I see you've already been answering some, so thank you so much for providing some of those. If you're curious, I think the audience can see those answered questions in the answered section of the Q&A. Let's start out with talking about implied or assumed consent. So as we are probably familiar with, there's lots of different ways that assent is sort of approached in the healthcare system. Could you all talk a little bit more about the ethics and the legality of implied and assumed consent?
Well, so you heard, so Dr. Shapiro mentioned that that is a recognized exception, perhaps the most recognized exception to informed consent. But right, if you're picked up by an ambulance on the side of the road, they're not getting your they're not getting your consent, much less your informed consent, because you may be unconscious, right? Nevertheless, they are allowed to transport you, and the ED is allowed to treat you, even though there's been no consent or informed consent. So, because as you say, we assume that the person would have consented if they could have. So the two really important limits, though, are you really have to have the inability to get. So if the person's spouse is right out there in the waiting room, well, then you could have gotten consent. So the idea is you can act on the basis of implied consent when you can't get quote unquote real consent. But if you can get real consent and there's time and opportunity to do that, then you should do that. The other real big limit is if you have reason to suspect that the patient wouldn't have consented. So Dr. Shapiro gave the example of a pulse. One of the most talked about examples in bioethics literature is the Jehovah's Witness. So if you know that this person was a Jehovah's Witness, you can't say, oh, we need to give them these foreign blood products because, and they would want that. And you couldn't do that on the basis of implied consent because you know if they could speak for themselves, they would have rejected that. So those are the two big limits.
Can you talk a little bit more about this idea of broad, like a broad consent, where a patient comes into a hospital and there's some things that they're assumed to consent to, right? And there's other things that they have to actually sign the form or go through the ritual, the process of getting signing the consent form. How is this decision of like what actually ends up going through the ritual of informed consent? How is that decided? Like from a bigger, more framework perspective?
You're the one that works in a hospital. I'll let it.
I can try. From a framework perspective, I think that there definitely does seem, and I don't know how, there's definitely, I think there's so many decisions that get made. There are so many things that happen to someone who's in the hospital. If we stopped and asked for consent each time and a signature and had a conversation, I need to start this medication, I'm going to go up on that medication, I'm going to get these labs, the act of caring for the patient would grind to a halt. I think there's definitely a bias towards getting consent for procedures that are invasive, right, that involve, placement of foreign bodies like endotracheal tubes or, catheters, or that involve in someone, or that involve painful things. And I think that especially when you think about the surgical context, you're asking consent because the patient is going to become incapacitated as they go into surgery through anesthesia, right? And so they can't at any point then, once it's started, say, wait, you know what, actually, I don't want to. Whereas if you are going along with medical care and your patient is doing well enough that they can continue to communicate with you, there is an ongoing opportunity for discussion or for a withdrawal of consent for ongoing therapy, right? And people do leave the hospital against medical advice, where people say, the physician says, I want to keep treating you, I don't think you're better yet. And they say, you know what, thank you very much, I will sign a paper saying that you have explained to me what you perceive to be the risks of leaving, and I'm going to accept those risks and leave anyway.
That's really helpful. Oh, go ahead, Dr. Pope.
No, I was just going to say, I think that they're often bundle like consent as a bundle, right? So you take something super simple, like you go to get your COVID vaccine at Walgreens, right? Well, they don't say like, hey, I'm going to do the alcohol swab. Now I'm going to do the thing. Now I'm going to put a Band-Aid. They don't ask each separate thing. They're like, hey, are you here to get a vaccine today? And that, of course, entails like 4 separate tasks that are part of that. But you don't break it up. And so at a hospital, it's even more bundled up together. That said, I do think we're going to have, this is going to be something the next 5 years or so is going to come under increasing scrutiny in bioethics, because one of the biggest issues in bioethics is what we call non-beneficial treatment or potentially inappropriate treatment. So if you're going to withdraw mechanical ventilation or dialysis or make a very big and discrete decision like that, yes, you need to get consent. Okay. But there's but the problem is there's a lot of stuff that gets real close to the line. So like, okay, we'll decide what the level of pressors is. We'll decide what the level of this is. And so, but a lot of those actually are consequential and may have really big, in other words, you're going to treat the patient less aggressively, but you haven't made any sort of big, open, discrete decision point there. And I think as the risks of some of those decisions get very high, people are pushing back and saying, well, yeah, that's normally been all within the scope of the broad general consent that we gave when we were first admitted, but some of that you should come and present to us separately because the consequences are so significant.
We've had a couple of cases just in my experience as an ethics consultant where we've had patients saying, you can't draw my blood, I have to consent to that. You can't take my labs or vitals, I have to consent to that. And it seems like what you're saying is that within this framework, there are things that require consent, things that have really high risk, things that are significantly invasive, things that will incapacitate the patient, but not every procedure requires consent.
Yeah, although this is a language problem, because what you just said, there's a difference between do you need to seek consent versus may you proceed in the face of an actual objection. So those blood draws, maybe you weren't going to ask, hey, may we do this blood draw? You were just going to do it. But if they on their own decided to object it, then that objection, I think, has some, you can't just ignore it.
That's a great point. That's a great point, right? Because objections can still be upheld, refusals of treatment can still be upheld, but that's different from does this procedure require the consent process? All right, that was great. Let's get back to our questions. There's quite a few questions in the chat about patients with cognitive impairment and disability, intellectual disability. So how would you all recommend approaching the informed consent process for cognitively impaired or developmentally disabled patients? Is there anything different that you would do? What would you recommend?
I think I would approach it as a pediatrician, I would approach it as I approach kind of the idea of assent. So if someone is cognitively disabled or developmentally disabled to the point that they lack capacity, presumably someone else is making their official medical decisions for them. But you should still involve them to the extent that you can in their decisions, right? So you should talk to them. You should make sure they know what to expect. You should seek their opinion. It is complicated when someone doesn't have capacity, and therefore if their decision maker said yes and they don't want it, then you need to decide how important a procedure is this, right? Is this urgent? Is this critical? Is it enough that we should say, I'm sorry, I don't care that you don't want it, it needs to happen anyway? Or do we have time to dig deeper into it and figure out what the source of conflict is and whether that can be ameliorated?
Yeah, I mean, I agree with that. So a few weeks ago, you had the talk with Dr. Henriksen about surrogate decision making. So if the patient is, completely unable to participate at all, zero, because of stage 7 Alzheimer's, or they're just unconscious, yeah, then that's almost easier, because you're like, okay, who is the appropriate surrogate to speak for this patient? When you say, I think the adjective was limited, so they have limited cognitive capacity. So that's trickier. And I think this is something that bioethics I don't think has really espoused yet. which is, it's been binary, I think, for a long time. Either the patient has capacity, she makes the decision, or we need a surrogate to make the decision. Now, Dr. Shapiro is right. In pediatrics, it's been a little mixed because of the concept of assent. But in the adult context, we still largely follow this binary model, right? Either you have capacity or you don't. But there's people who have some capacity. And so increasingly across the country, we're seeing the concept of supported decision-making, where you don't have a surrogate to make decision instead of you, you have a supporter to help you make the decision yourself. And I think we're going to see more and more of that, because the general trend is, to the maximum extent possible, the patient should participate herself. So if there's a little bit of cognitive capacity left, use it. Let's hear from it.
Fantastic. So in a limited or in a similar vein, let's talk about psychiatric patients, because there are times psychiatric patients often have fluctuating capacity, right? So how do we approach informed consent with our psychiatric patients, perhaps in emergency situations and in non-emergent situations?
Well, so this goes back a couple talks, right? Because you had a separate talk on capacity. I do think it's one of another widely misunderstood concepts that capacity is decision specific. So again, it's not like you have it or you don't. You might have it in the morning, but not in the afternoon. You might have it on Monday, but not on Tuesday. And so again, when the patient has capacity, then she should be able to speak for herself. I think that's a challenging situation. I think, and here's a piece of good news. We are just generally across the United States pushing people, pushing might not be the right word, but encouraging people to complete psychiatric or mental health advanced directives. So we've always pushed people to do medical advanced directives, but the idea is maybe in your incapacitated state, you're going to reject these psychotropic drugs, but when you're in a more calm and reflective and deliberative state, you think, oh, I would want them. So it's almost like a Ulysses clause where you're saying, listen to me now, even if my future self in a incapacitated state rejects it. I authorize you to ignore my future self's objections, because I think that those Ulysses clauses, those psychiatric advanced directives, help resolve that the clinician's conflict, which is, well, who do we listen to, the past self or the now self?
Mm-hmm. Would there ever be an instance where, say, there's a procedure that usually you go through informed consent, let's say like ECT, usually you have to go through an informed consent process with ECT, right? You have to let patients know what's going on. You have to do that intake process, or to that risk intake process. Would there ever be a scenario where it would be appropriate to not disclose to the patient about the kind of procedure that they're going through? Like why would we need to disclose, and why would we not disclose to this patient in the informed consent process? So I mean, that's the question. I know it was a little complicated, but
I don't like the fact that you chose the ECT example, because ECT is such an extraordinary intervention that it actually requires super informed consent. Right. So maybe you did that deliberately, but it's like sterilization, right? It's a super special sort of thing. Well, I would go back to Dr. Shapiro, right? Because there are exceptions to informed consent. I mean, obviously, if the patient lacks capacity, then you're not talking to the patient, you're talking to the surrogate. There is an exception that's been around for 50 years that she didn't put on the slide because it's super questionable, which is the therapeutic privilege exception, which is the idea is, if we tell them, if we do informed consent, they're gonna freak out, right? And it will actually be bad for their health. Informed consent will harm them. So you're gonna that's gonna be a very special case where you can show a link between the fact that you're doing an informed consent discussion and that will lead to a clinical deterioration of the patient's condition. I think there are gonna be, once in a blue moon, those two things will be causally connected, but it's super rare, and you got to be super careful if you're ever going to invoke the therapeutic privilege exception, because typically when clinicians think it's appropriate, what they're really thinking is, I'm not going to tell you because you're going to make a stupid decision. So therefore which is different. That's not an appropriate use of the therapeutic privilege exception.
So it can be really hard as a clinician to parse out what is the potential for actual, real, physical, clinical harms, and what is my understanding of a bad decision, right? Sometimes we can misinterpret what is actually a bad decision as this could be a clinical harm. And that's why we should be a little more suspicious of that therapeutic privilege exception that has been touted and has been shared. But we're sort of, it sounds like our position would be, this actually has a lot of room for ethical wrongs to take.
I think it's so rare and it's so tricky that I think you would always want to run this through your ethics mechanism before you invoke the therapeutic privilege exception, because you want people, well, you want people trained in ethics, but you even want just other people to weigh in on this to make sure that this needs to be vetted.
It's not a decision to make alone.
Because it really is extraordinary. Because it goes back to pre-1970, right? It's paternalism. It's like, I'm going to make a decision for you, rather than empower you to make your own decision. So it brings us all the way back to, 1950s paternalism. So you really have to think that is a red flag. Now, it possibly once in a blue moon justified, but you got to pause and vet that carefully.
Let's talk about some other exceptions when paternalism might actually be ethically justified. And this is a really tricky question, and I want to hear your perspectives. Are there ever moments where clinicians should not necessarily seek consent for major interventions? Anything like so let's say we have some family who comes from a culture and a context where informed consent is not necessarily seen as part of the context that they come from, right? Or we can also have a family who has a religious obligation that prevents them from consenting to procedures that would result in their family member's death. Typically, we have consent processes that we have to go through, but would it ever be ethically appropriate to not go through this consent process to accommodate the cultural understanding of this family?
Yeah, that's a great question. I think yes. It's a challenge, right? Because we have all the rules that we've developed are very Western individual focused, but of course, Chinese and some Eastern cultures are more, don't focus on the individual, but they focus on the family. And so what happens which of course there are lots of immigrants and lots of visitors, when the healthcare system has been developed with a certain set of rules, but the rules that they follow are a different set of rules. So whose rules do you follow? I think it's a great question. It's a hard question, but I do think can be circumstances where you can justifiably, I guess, as you say, leave the patient out of the loop. If confident that that's what she would have wanted to be kept out of the loop.
Mm-hmm. I think that sometimes someone like a cultural broker can be really helpful here, right? Someone who can straddle both cultural spaces and understand, both to help you understand why you wouldn't go through your normal procedures, and also to help you navigate a conversation where, I think you could even say, this is something that in some circumstances we would ask permission for other places. Like, how would you like us? And sometimes this is a question you ask to the whole family. How would you like us to proceed? Recognizing that you guys are making decisions together as a family, how should we, or that you don't want to. People tend to make it clear. I think we are uncomfortable kind of getting to the issue of waiver, right? If one of the options on the table, one of the risks is on the table is death, and someone says, no, don't tell me, I don't want to know. That does, it makes you as an operator feel really uncomfortable, right? Like, they could die and they didn't let me tell them that. And do I feel like I can rightly kind of take on this task without it? So I think it's something that requires a community, right? Support of ethics and of cultural brokers to help navigate.
Absolutely.
Just on your original question, apart from that culture question, the other big case where you can do something without informed consent is in extreme cases where the treatment, you're making a major treatment decision, but it would have been basically completely ineffective, right? So sometimes you can write a DNR order. So that's a big decision. You're changing somebody's code status. But if CPR wasn't going to work to restore their circulation, then it's what we would say is futile. That's okay. So there are situations where you can basically change the treatment pathway, not only without consent, frankly, even over the objections of the authorized decision maker. This happens all the time, even in Minnesota. But it's where the treatment at issue is really either completely ineffective or the burdens of that treatment, there's basically almost no benefits of that treatment, but the burdens are very, very high. So it's very unbalanced. So I think that's another situation where you can proceed without informed consent.
And both of these situations are so like procedurally complex, right? We would want to ensure that there's multiple levels of eyes, ethical analysis, administrative input. Like these are not just individual doctors making a decision like, well, I'm done with the ventilator, we're done, right? These are kinds of things that involve a significant process in order to do well.
Absolutely. The normal rule is you need the patient's informed consent. So anytime you're not following that pathway, you got to be thinking, okay, I'm not doing the normally correct thing. And so pretty much everything, any other pathway does, yes, need to be vetted with due diligence or procedural due process. Yes.
Great. Well, we are over time. Thank you, Dr. Pope and Dr. Shapiro, so much. This has been such a fantastic session. Thank you for answering the hard questions. We really appreciate it. Thank you all for attending. We will have another session coming up for Unpacking Bedside Bioethics and a few more sessions for our Ethics Grand Rounds for the Center for Bioethics. So please see that presentation details document for more information. Thank you for joining us, and we'll see you next time.